So thank you so much, the organizing committee, to invite me to talk today amongst an amazing group of speakers and organizers. And as Dr. Adiba said, yeah, I was one. I attended this meetings when I was like in medical school and also when I was in my internal board of medicine. And now I'm a speaker here. So I hope you enjoyed this talk today. They asked me to talk about obesity and malignancy, so I'm going to go through the risk of obesity in general, and we're going to talk about some epidemiology, and also, is there a risk between obesity and prevalence of cancer globally and locally? I'm going to go through also some definitions in terms of hallmarks of cancer, the types of cancer, and its relationship of obesity, and as well, maybe we can think together about prevention strategies. So as an introduction, we know that probably all the speakers talked about that obesity is a major health problem associated with multiple clinical conditions and disorders. No one, we all know that it's a risk factors of developing multiple diseases such as diabetes mellitus, cardiovascular diseases. It can also affect our musculoskeletal system with increasing the loads on our joints and can cause osteoarthritis, can cause sleep disorders, can cause mental illnesses as well. And is there a relationship between obesity and cancer? We have a category of cancers that are caused by obesity. We call them obesity-related cancers. And these are sometimes can be solid tumors, and sometimes they can be also hematological tumors, such as myeloma. Definitions of obesity. So we have different definitions of obesity. Sometimes we rely on the body mass index, and I hope you know what's the definition of that, which is like the weight over the height squared, and also some other measurements we can use in order to define obesity, such as the waist circumference and the waist hip ratio. And we know that as the waist circumference increases, it also can lead, or it's associated with metabolic disorders, and we know those metabolic disorders and metabolic syndromes have a risk of getting inflammation in multiple body organs, and this inflammation will lead to medical disorders. We also, know that excess body fat, speaking about the waist circumference and the waist hip ratio, can have an association with increase of cancer-specific mortality of approximately 17%. So it's always important to educate patients about obesity, educate the patient about how can we control excess body fat, and how can we control obesity based on the categories of the obesity. So we know that, again, BMI is an important factor, or like an important something that we need to measure in patients, and we can, based on the BMI, we can categorize or define obesity. So patients who have underweight or healthy patients, the BMI are like either less than 18.5 or up to 24.9, but when we go about 25 of BMI is an overweight, and we can also go to obese and severely obese. And severe obesity is associated, as I just mentioned, with a lot of medical disorders. So WHO had defined what are the attributable risk factors that are related to obesity. And these include the dietary factors, maybe like consumption of energy-dense food and sugar-sweetened beverages. So we always try to control those and educate patients about trying to limit the intake of those food substances. Again, lack of physical exercise and sedentary behaviors. We know that nowadays, like even shopping, like 10 years ago, we need to drive our car, we need to walk, especially for those who are married. Maybe they can walk like 5 or 10 kilos in a shopping mall. But nowadays, you can do all of that while you're sitting at home, just ordering whatever you want, from food, from clothes, from any substance that you can order, and this also leads to sedentary behavior. So lack of movement increases the risk of obesity, as well as some other genetic factors. So we know some people have inherit maybe like bad habits, or inherit some genes from their family that led to development of obesity. Other environmental factors, urbanization, cultural and social factors, as we know in Kuwait, and those late dinners, and biological factors as well. So, in a late WHO article, they mentioned, and that was published back in 2021, they mentioned that obesity-related tripled since 1975. And in 2020, 39 million of children were either overweight or obese. By 2025, if we stayed on this rate, around 2.7 billion adults would be overweight. Of those, 1 billion would be obese, and of those, 177 million would be extremely obese. And by 2030, approximately 38% of the world's adult population will be overweight, and another 20% will be obese. And this definitely will lead a burden on the health system, and also by affecting and development the obesity-related other medical conditions and also cancer. And in US, again, in a publication that was released in 2020 showed around 32% of adults aged 18 or older were either obese or severely obese. So what can we do about that? Another figure, or like another number I would like to share with you here, in the International Agency for Research on Cancer, in their 2020 report, they found a strong evidence for obesity and the risk of 13 different types of cancer. So there is a big relationship between obesity and cancer. And as a risk factor by itself, obesity attributes about 4 to 8% of development of all cancer, and more specifically, those 13 cancer, which I'm gonna explain in my coming slides. Before going into that slide, I would maybe, I don't know if you can look, read the slides here, but I'm gonna just go through them. This is like an important article that was published by Dr. Hanahan about the hallmarks of cancer and the definition of cancer. How are these cancer cells are characterized? So those cancer cells can share different characteristics. Of those, like they can evade the growth suppressors that can lead to development and more proliferation of cells. They can avoid immune destruction. They can avoid, or like they can enable immortal replication. So we know that, as we age, the proliferation rate decreases, but here in cancer cells, as we age, some of those bad cells, they continue to replicate without stopping. And this can lead to inflammation. So we know that tumors can promote the development of inflammation. They can activate invasion of the other systems. So we can look at some of the tumors. Basically, let's say the tumor was on the pancreas, it can invade the vasculature around that, and that can lead to fatal consequences sometimes. And we know that the other characteristics, that they can produce genomic instability, they can induce the development of vasculature, and this is a way where cancer cells can escape the origin, المنشأ. So the origin of the cancer, let's say if it's in the lung, and it goes all the way to the brain, or it goes all the way to the liver, it means that it went through those cancer cells. They went through our blood circulation, and through their way in the blood circulation, they can deposit anywhere else in the body, and this would take this cancer from a local or an early stage cancer to a late stage or a stage 4 cancer, and this would affect the prognosis, and this as well as affecting the types of management that we can provide for patients. Other things that those characteristics of cancer cells, they can dysregulate the cellular metabolism, and they also have sustained proliferating signaling. So we know, let's say 10, 15 years ago, we thought that cancer of the breast is just like one cancer. So all patients who develop breast cancer, it's just like one disease, and for that one disease, it's just like one treatment. And this is what we learned about that. We can categorize breast cancer to hormone-positive breast cancer, so these patients will not be treated with chemotherapy. They can be treated either with surgery or they can be treated with hormonal treatment, which is just a tablet. Instead of getting those patients into the debilitating effects of chemotherapy, we can avoid that, because those cancers are getting those signal of proliferation from the hormones. It's not something else, so we can just block the hormones. So by understanding all of these characteristics, we can categorize cancer cells, and based on that, we can treat cancer. Okay? So these are the 13 cancers that are associated with overweight and obesity. Thyroid cancer is one of them. Breast cancer is a very common cancer, especially in our region. It's the most common worldwide cancers in females, and we know that in October they also always have these health awareness months that ask patients to try and do the screening through mammogram. Obesity is also related to liver cancer. Liver cancer, we know that obesity can lead, and metabolic disorder can lead to the development of non-alcoholic steatosis and fatty liver disease. And chronic inflammation is one type of risk factors that can lead to development of cancer in general. And here, this is maybe one of the mechanisms that patients can develop liver cancer that are not associated with, let's say, hepatitis B inflammation or infection. It is also associated with gallbladder cancer, upper stomach cancer, pancreatic cancer, colon and rectal cancer. It is also associated with gynecological cancer, such as uterine and ovarian cancer. Multiple myeloma, which is the hematological cancer, it's not a solid tumor cancer. Adenocarcinoma of the esophagus, as well as meningioma. And this is a systematic review and meta-analysis that was published back in 2021. They studied 203 studies with data from more than 6.3 million participants. And one of the conclusions this meta-analysis came with is that obesity is associated with increased overall and cancer-specific mortality, especially among patients with breast, colon, and uterine cancer who are obese. As well as it's not only associated with an increased risk of cancer, but may also increase the risk of recurrence of early-stage cancer and be correlated with inferior outcomes. So let's say there is a patient who developed cancer, like an early-stage breast cancer, and this patient was having a normal body weight. When we compare those groups of patients with patients who are obese, we know that patients who are obese unfortunately have a higher risk of recurrence of cancer despite being treated. So what are the mechanisms that maybe can lead to the development of cancer? We have different types of mechanisms, as most of these mechanisms are just like theories. One of these theories is like inflammation. We know that obesity is associated with increasing risk of chronic inflammation, as I mentioned, and that can lead to changes in the DNA that can lead to DNA damage or DNA mutations. Bad mutations can lead to proliferation of, I would say, like abnormal proliferation of the cell, leading to development of cancer. It can also affect our hormones, so it can cause hormonal changes and alter the level of hormones such as the estrogen, testosterone, insulin, and insulin-like growth factors. These changes can lead to the development of cancer. It also can cause malfunction of the immune system, so obesity can impair our immune system ability to detect and then eradicate our body from these bad cells, or basically cancer cells. And also it can lead to increase of the production of adipokines from the adipose tissues, and that can also lead to or promote cancer development. So this is a recent study that was published back this year in January 2023. It looked at an overview of epidemiology and pathogenesis outcomes and how can that affect the management of cancer. So we know that excess body fat or excess adipose tissue can lead to changes in the lipid metabolism. This also would lead to insulin resistance, as we know, that can alter the hormones, specifically the sexual hormones, adipokines release, immune dysfunction, and that can lead to microbiota diabetes. dysbiosis, sorry, and this can also lead to the chronic inflammation. This is what I just, like what we looked at in the previous slide, leading to fibrosis and extracellular matrix remodeling. This cycle can, like if it goes on and on, increases the likelihood or increases the risk of development of cancer. So we need to break the cycle as early as possible. This is, again, back to the International Agency for Research of Cancer. This is, it was published in 2012. This is basically a fraction of, or like a percentage of cancer cases among both sexes attributable to excess body mass index, and that's shown by the country. So as we can see here, the red, orange, or like, does this work? I don't think so. Okay, so as we can see, the GCC is labeled by red or like this dark orange color, and this means that there is a high percentage of obesity as an attributable risk factor to the development of cancer. And as we can see here, Kuwait ranked among the top 10, unfortunately, countries in terms of having obesity and obesity-related cancer, and we ranked 6th back in 2012, unfortunately. So we need to work on that. We need to educate patients about obesity and the risk of obesity in general, and specifically the risk of obesity and cancer. And we need also to work on that. We amongst the 10th, let's just take it down the schedule here. And also Saudi Arabia was ranked 10th. So the GCC countries is, like we have different risk factors, mainly because of obesity and obesity-related disorders, and what these consequences in patients or in our population to develop cancer. Excellent, thank you. Another data I found, it was published back in 2014 in Kuwait. This is a Kuwaiti data, again, that showed that the frequency of being overweight or obese also in men, about 42% versus 32% of that population or that cohort. I think it was around 3,500 people. On those people, we found a high number of an increased body mass index, basically. So this is, again, obesity. We know that obesity is prevalent in our community, and unfortunately, we need to explain that, again, obesity is bad to your health. Obesity can give you cancer. Okay. Would cancer how would obesity affect our choice of cancer treatment? So we know that sometimes, unfortunately, weight gain is common in patients treated with chemotherapy, because some of the chemotherapy, such as taxanes, we need to supply the patients with some steroids, and we know that steroids can cause water retention and weight gain. So those patients, and also we know that patients who receive, like, let's say for breast cancer treatment, that can lead to early menopause. This can affect their bodies and cause increased body weight or body or fat distribution. In those patients also, there is something that we call sarcopenic obesity. Mainly, it refers to the loss of muscle mass and then concomitant gain of adipose tissue. So basically, it's just like those patients' muscle mass is being replaced by fat cells. Sometimes I also remember a patient that was severely obese. I saw her once in my clinic, and as you know, some of those, the chemotherapy that we need to calculate the dosage based on the body surface area. So that patient, I remember her body mass index was, like, she was severely obese, so she was up around 45 or 50 in terms of BMI. And then when we calculated the body surface area, we saw that we reached the maximum dose of the chemotherapy. So, and the patient needed much more than that. So this also can affect the safety data, and we do not have a lot of data in terms of obese patients, and is it safe to go beyond those numbers to treat those patients? So, and this definitely impacted her choices of treatment. ASCO, which is a very a famous organization in terms of publications in terms of protocols of treatment of cancer. Basically, it's the American Society of Clinical Oncology released a guide a treatment guide for oncology providers that looked at the obesity and cancer specifically. And what they suggested is that we always need to assess our patients' weight by evaluating their body mass index and how would that affect our treatment dosages and treatment options. We also need to advise our patients to lose weight and try to control their weight if they were overweight or obese by promoting physical exercise. And we have a lot of data that proves that patients who are physically active usually do better than patients who are sedentary and doing, the gaining weight or they're not physically active, basically. And also we can always refer those patients to our colleagues to the obesity treatment units, the medical nutritionist, the medical obesity specialist, as well as sometimes we know that the GI doctors, we have different approaches in patients and techniques that we can do ballooning as well sometimes in some of those patients, especially I'm talking about patients who are either cured with their cancer or patients who have an early stage cancer. We can always discuss weight reduction management with those patients. And, basically management of obesity and cancer survivors. So now those patients were treated for cancer and they are home right now. They do not have cancer. We always need to keep them on track in terms of following up with their diet, with their exercise, behavioral therapy, and drug therapy. We do not have safety data about the new treatments, such as the Ozempic and Saxenda. Maybe, sorry, I do not know the scientific names for those, but we lack safety data especially for those patients who were diagnosed previously with cancer. So, what our prevention strategies or solutions may be? We can always try to play this role as health providers, that we need always to educate our patients or our community about the risk of obesity. We need also to educate them about nutrition. Maybe why can we give some courses for patients in college or even in high school? We always need to highlight the benefits of physical exercise and always encourage people to join the gym, to go do some physical activities in school and to, have more physical exercise by walking. And also, early referral to obesity management, as I mentioned, with the medical nutritionist, obesity management specialized units, and weight reduction surgeries in some people. Other strategies here, we can stop people accept cookies, whether it's the cookies that we eat or the cookies that we see in Chrome or in Safari. By that slide, I finish my talk today. Thank you so much for listening.
I'm sorry, Dr. Abdulaziz, but I'm going to ask you to step back. We have a few minutes for questions before we start our last talk. Dr. Youssef? And thank you very much for a wonderful talk, by the way.
Thank you so much.
As you know, these cancer patients are highly depressed. So can you comment on, is there any relationship between weight loss and depression? And how would you tackle such a problem?
Weight gain or weight loss with depression?
No, I'm talking about they are obese and they have cancer. They are depressed.
Yes.
How would you treat them?
Exactly. That's a very good point. We know, as I mentioned, obesity by itself can increase the risk of having mental illnesses such as depression. Add to that the risk of depression that sometimes can come with cancer. Add also to that the risk of depression or mental anxiety that patients can get from our treatment. So we know some of our hormonal treatments can induce anxiety and depression in patients. In our practice in the Kuwait Cancer Center, we have a psychiatry OPD once every 2 weeks that we always try to follow up the patient. If they have any symptoms of depression or signs of depression, we can always ask them to to encourage them to talk about that, and we can always refer them to the psychiatry OPD. And sometimes we start those patients of anxiety treatments as well as antidepressants that maybe they need it, especially when they show signs and symptoms
Which
of
makes
depression.
their obesity worse with antidepressant.
I know, but at this time, like, we are treating something that is also, like, harmful to their body. We're treating cancer. So if we combine cancer treatment with depression treatment, as well as we can also educate patients that we know there is a risk of gaining weight with those antidepressants, so we can also refer them to the medical nutritionist and also answer their questions in terms of what other stuff that we can do to decrease the percentage of body fat, maybe by doing more exercise. So we always encourage our patients to exercise even when they are stage 4 cancer. They are like in Canada, some of the patients used to go hiking on the season of hiking while they are stage 4 cancer being treated. So
This is in Canada, not in Kuwait. In Kuwait, they are most of the time sleeping in bed. Okay?
Yeah.
But I think the answer is in the era of such good treatment.
yeah.
Then you can start on antidepressant and start on anti-obesity drugs. Then they will do well.
Exactly. This is like I just touch base on that because we do not have safety data on some of those medications and its relationship for patients who had cancer or who are actually being treated for cancer. So to me, I would always advise patients to do the non-pharmacological types of management, but then we can always refer them to obesity management treatments, and then we'll see if the benefit outweighs the risk. We can always discuss that with our patients. Very good question. Thank you.
Great. Any more questions? Yes,
Dr.
Dr.
Nabi.
Thank you, Dr. Abdulaziz. It's really amazing, your lecture. Really now we are in the era where we are using more and more of hormone receptor agonists or stimulators in treating diabetes or other comorbid conditions. Specifically speaking about the GLP-1 receptor agonists. Now, what's your advice for if you want to initiate GLP-1 receptor in patients who are cured from cancer, particularly breast or colon? Now, with thyroid, we know that it's sometimes contraindicated.
Exactly.
But the breast and the colon, which is more common, we are facing every day. So, any advice?
So yeah, like as far as I know, we don't have any data that tells us is there any risk on breast cancer with those categories of those specific medications. So we tell them that if that is necessary to control your diabetes, for example, just go ahead with that, right? And we have a lot of patients who are receiving these treatments to control diabetes. But if those patients, I would say, like whether they are cured or whether they are currently being treated, in terms of obesity management use of those medications, as far as I know, we do not have any data that looked at the safety of those medications for this category of patients. So we always, better to have a discussion between whether the endocrinologist or the obesity specialized doctor, to have a discussion between us, again, to look at number one, what type of treatment this patient is taking. So we now, in terms of systemic treatments, we have chemotherapies, we have immunotherapies, we have targeted treatments, we have hormonal treatments. And we have also radiation treatment, right? So I would say we would take it case by case. I would say if the risks or the benefits outweighs the risk in those patients, maybe we can start slow. But we also need to look if there are any updates on the data, like safety of data on development of other, other than their thyroid. Is there any data, some alarming data about the use specifically for patients who are being actively treated for cancer? But yeah, if there is, I would, number one, wait for, any observational data, but number two, if the patient really needs that and that would improve the outcome, then I would use it.
Okay, so thank you very much, Dr. Abdulaziz. It was a pleasure having you.
Likewise, thank you so much.